It's my privilege today to start this webinar on hip and groin pain. My subject is the dancer, and specifically the ballet dancer. It's not usual for young people to have hip pain, but we know that dancers do extraordinary things, and it's our job to understand what they do and try and support them in their efforts. Ballet dancers are selected into the profession based on their physiques. External rotation of the hip is the most screened part of the body. Dancers stand in turnout, externally rotated from the hip down to the foot, and it's a prerequisite. Generalized hypermobility is expected. Proportions, a longer lower limb to a shorter trunk, is what is expected and deemed more aesthetic. Spinal mobility, especially extension, is necessary. Hyperextended knees are considered the aesthetic of choice, along with the hyperplantar flexed foot and ankle. This makes the dancer's lower limb line. But ballet technique requires strength, control, a wide range of movement with sustained as well as ballistic moves, local muscle endurance, agility, speed, and cardiovascular fitness. So the fragile structure of the ballet dancer who is selected today does not really match the challenges of the technique. Considering hip assessment, normal stance and gait need to be observed. Dancers tend to walk out-toed with a posteriorly tilted pelvis. Neither is normal stance or normal gait. The single knee bend is examined. Posture in external rotation needs to be observed because dancers tend to alter their posture once they have turned out the hips and the knees. Single leg standing in external rotation needs to be examined for control of turnout on the standing side, as in this photo. Pain provocation moves on both sides need to be observed. Dancers often tell you exactly what's going on with them. A demo of clunking and clicking. Passive ranges of movement are measured, including external rotation of the hip in neutral and at 90 degrees flexion. The obus is measured if any suspicion of muscle imbalance is noticed. Flexion, adduction, and internal rotation is tested. The Fabers is tested. Any difference from side to side may indicate a tight anterior capsule or psoas spasm. The log roll is examined, looking for that passive spring back into external rotation, which suggests microinstability. The ligamentum teres pain provocation test is examined. Frequently in professional dancers, there is a teres ligamentum tear or rupture. Muscle strength is tested, iliopsoas, lower gluteus maximus, the adductors, gluteus medius, and the lumbar spine range, including side flexion, which is so important in abducted moves, needs to be free. And lower abdominal activation and stability is very important. No one really is talking about transverse abdominis these days, but it's important for the dancer for stability of the pelvis. This young dancer is demonstrating a move and a range of movement that is aspired to by all young dancers, but not everyone has the same physique or that facility. Hip joint morphology in dancers has been looked at by several authors and researchers. Harris et al. At Houston Ballet used plain X-rays and looked at males and females in a professional company. They found dysplasia and borderline dysplasia at 89% in at least one hip in their cohort. Cam deformity was in 25% of hips, with males more than females. 74% had at least 2 out of 6 radiographic signs of pincer deformity. Mays, in 2016, an Australian ballet, used MRI and looked at 49 dancers and 49 age and sex matched athletes. They found much less dysplasia and borderline dysplasia in their dancers. Dancers had more acetabular retroversion than athletes. Dancers had a higher mean femoral neck shaft angle than athletes. Dancers trended towards lower lateral central edge angle compared to athletes. Female dancers had similar anterior alpha angles to the athletes, but dancers had significantly lower superior alpha angles than the athletes. The provocative moves for these hips are so often abduction and external rotation, elevation of the leg over the horizontal line, which can expose the hip to impingement and loss of congruence. Another demonstration of exactly this move. So with these provocative moves comes capsular and iliofemoral ligament microtrauma. Capsular laxity is caused by those repetitive rotational stresses. Ligamentum teres sprain, tear, and ruptures are common and lead to further microinstability. Hip subluxations in extremes of motion, labral pathology, iliopsoas tendinopathy, snapping iliopsoas tendon over the femoral head and underlying structures, cam impingement, cartilage defects. Each of these photographs shows young dancers in compromising positions. This professional dancer has settled into a comfortable position for her. She's hypermobile, and once the physique reaches the end of range, it can relax. However, this is the position with the highest frequency of femoroacetabular subluxation. It's called box splits. Impingement zones were located in the superior or the posterior superior quadrant of the acetabulum in this position. Concerning, though, is the encouragement of this risk-taking position in very young dancers. And unfortunately, it's become ballistic with these young male dancers. So something that can start as a repetitive strain on the labrum and the acetabular rim can become a traumatic injury. We measure hip rotation very carefully, and we measure it in neutral. The upper photograph shows the measurement in the research done by Washington, who found that 45 of professional dancers had an average passive external rotation measure of 50.2 degrees, and that was in the neutral hip and pelvic position. The functional range, though, is what the dancer uses and where they choose to stand in the turned out positions. In the lower photograph, it's a very conservative angle being used here by a male dancer. Most dancers push much further than that. And Washington found that the functional range used was on average 68.3 degrees, with distal joint and capsulo-ligamentous structures absorbing the remaining 18 degrees. Considering label tears, Duthon et al. Found no difference in prevalence in elite female ballet dancers compared to a control group. Mays identified labral tears in 51% of 196 hips, with no significant difference in prevalence between the two, the dancers and the sportsmen, or between sexes. Labral tears were not significantly associated with clinical measures such as pain, functional scores, or rotation. And there was no relationship between bony morphology and labral tear. What's more, pain provocation tests using internal rotation and 90 degrees flexion had poor sensitivity in identifying labral tear in the presence of hip pain. Mays et al. Found that larger sized effusion synovitis was found in 16% of dancers and not present in athletes. The female dancers with effusion synovitis had higher levels of pain and lower levels of function than those without. There was a weak association between effusion synovitis and cartilage defects. Impingement type bony morphology was related to cartilage defects but not labral tears. Male dancers develop cartilage defects at an earlier age than female dancers and athletes. So increased range requires low acetabular and femoral version angles, acetabular dysplasia, high neck shaft angles, greater concavity of the head-neck junction, less coverage, and ligamentous hyperlaxity. Structure, however, can be measured fairly accurately with radiology. But function is harder to assess. It is, however, easier to adjust. Postural assessment is important in the externally rotated position, as I've already said. The position of the pelvis dictates the position and congruence of the hip joints. A neutral stable pelvis, not the habitual posterior rotation, which alters femoroacetabular dynamics and adding stress to all hip structures. We discourage stretching out the anterior hip structures, and the neutral lumbar spine is supported by the deep abdominals. Working within individual capabilities of external rotation is very important. Balance of muscles stabilizing the hip joint, the strength of the hip rotators, biomechanics of the foot influence the hip stabilization above. Just that contact with the floor can enable a better proprioception within the hip joint. Considering the increased risk of premature cartilage loss in male dancers requires greater care in the training years. Considering hypermobility, the global hypermobility of connective tissue and the hip morphology allow a greater range of movement. The Beighton scale, however, does not include the hip, lumbar spine, or foot and ankle, and is considered lacking in specificity. The more hypermobile a dancer is, the more important biomechanics, control, and strength are in training and education. Strength development in the hypermobile physique is challenging, and so is control, due to proprioceptive deficits we find in hypermobile joints. Considering rehab and prevention of hip injury, It is appropriate to screen before intense training. We should be discouraging resting in hip compromising positions and overstretching. We should be discouraging stretching, particularly the anterior structures of the hip. There should be more concentration on training mechanics and adjustment for individual physiques. There should be an emphasis on control before strength. There needs to be a reduction of end-of-range dynamic moves until strong and control enough. And there needs to be that global appreciation of hypermobility. If choreographers were controlled and educated, and teachers participated in continued professional development, the risk to dancers' hips could be reduced. I shall finish there. Thank you very much.